بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Peace, mercy and blessings of God. Coronary blood flow. Agenda. Normal coronary physiology. Introduction. Factors affect coronary blood flow. Metabolic factors. Autoregulation. Diastolic pressure time index, coronary flow reserve, neural, hormonal, mechanical factors. Altered coronary physiology, obstructive coronary artery disease, non-obstructive coronary artery disease, endothelial dysfunction, overloaded states. Normal coronary physiology. The anatomy of coronary arteries. Right coronary artery from right coronary cusp. Left coronary artery left main coronary artery from left coronary cusp, giving and widest in the left anterior descending artery in the anterior interventricular septum, and left circumflex artery in the left AV groove. This is the anterior view of the heart, RV and LV and apex. This is the posterior view of the heart. Left atrium and 4 pulmonary veins. Aorta, right coronary artery, divides into posterior interventricular artery, gives ventricular branches to the ventricular walls, and marginal artery supplies wall of right atrium and right ventricle. The left coronary artery divides into circumflex artery supplies walls of left atrium and left ventricle, and anterior interventricular artery supplies ventricular walls. The cardiac veins drains into the coronary sinus into the right atrium. Introduction. Resting coronary blood flow in the normal status, approximately 60 to 90 milli per minute per 100 gram of myocardium, or 225 milli per minute, about 4 to 5% of the total cardiac output. Coronary blood flow during muscular exercise, of course, it will increase up to 4 to 5 folds to supply extra nutrients needed by the heart. Factors affect coronary. The third metabolic factors after adenosine and endothelial derived factors, oxygen and CO2 tension. Decreased tissue oxygen tension results from reduced oxygen supply or increased oxygen demand, causes vasodilatation. Hypoxia induced vasodilation may be direct or indirect. Direct as inadequate oxygen to sustain smooth muscle contraction or indirect production of vasodilator metabolites. Peripheral chemoreceptors in carotid and aortic bodies, and central chemoreceptors in medullary neurons primary function to regulate respiratory activity. This is an important mechanism for maintaining arterial blood oxygen tension, CO2 tension, and pH within appropriate physiological ranges. Carotid bodies are located on the external carotid arteries near their bifurcation with the internal carotids. Each carotid body is a few millimeters in size. When hypoxemia results in a oxygen tension lower than 80 millimeter mercury, elevation of CO2 tension above a normal value of 40 millimeter mercury, or decrease in pH below 7.4 causes carotid body receptor firing is stimulated. If respiratory activity is not allowed to change during chemoreceptor stimulation, thus removing the influence of lung mechanoreceptors, then chemoreceptor activation causes bradycardia and coronary vasodilation, both via vagal activation and systemic vasoconstriction via sympathetic activation. If respiratory activity increases in response to chemoreceptor reflex, then increased sympathetic activity stimulates both heart and vasculature to increase arterial pressure. Decrease in carotid body blood flow occurs during circulatory shock, also increases receptor firing. The fourth metabolic factor is ATP sensitive potassium channel. These channels are involved in adenosine-mediated coronary vasodilation because sulfonylurea derivative glybenkylamide, which is the potassium ATP channel antagonist, significantly impairs adenosine-induced vasodilation. Under normal baseline conditions, blockade of ATP potassium channels with glybenkylamide, which is the antagonist for it, results in decrease in coronary blood flow by 12 to 25%, with little or no change in myocardial oxygen consumption, demonstrating that the ATP potassium channels contribute to basal coronary vascular tone. Metabolic factors are ended now. The second factors affecting blood flow in this lecture is coronary blood flow autoregulation. What about it? During resting conditions, coronary blood flow is maintained at fairly constant level over a range of aortic pressures by process of autoregulation. As aortic pressure decreases, coronary blood flow is maintained by dilation of resistance vessels. So it is a process which maintains coronary blood flow at a fairly constant level over a range of aortic pressure. The resistant vessels of arterioles. These are small vessels proximal to capillaries and are below resolution of coronary angiography. Conversely, as aortic pressure increases, the resistant vessels constricts. So, during normal resting condition, coronary blood flow is pressure dependent. When pressure is extremely low or high, autoregulation is overcome and the coronary blood flow becomes pressure dependent. What about at very high perfusion or at very low perfusion pressures? At very high perfusion pressures, vasoconstriction is maximal and an additional increase in pressure results in a linear increase in blood flow, but at low perfusion pressures, the resistant vessels are dilated maximally and any additional decrease in pressure results in a linear decrease in blood. At pressures less than 70 mm mercury, the pressure flow relationship becomes linear, with blood flow decreasing in direct proportion to the decrease in perfusion pressure. At extremely low perfusion pressures, approximately 20 mm blood flow ceases altogether. This effect is called the vascular waterfall phenomena, which is caused by compressive effects of extravascular intramyocardial pressure, the critical closure pressure or the critical flow pressure, the pressure at which flow ceases. What about the third factor affecting the coronary blood flow, which is diastolic pressure index? What's its definition and what factors affecting it? Definition: it is the product of the average difference between aortic and left ventricular cavity pressure and the duration of the diastole, the area between diastolic aortic pressure and left ventricular pressure curves. Coronary blood flow is closely correlated with diastolic pressure time index. Factors affecting diastolic pressure time index: 1. Aortic diastolic pressure. 2. Left ventricular diastolic pressure. 3. Duration of diastole. Coronary blood flow is decreased by systemic hypotension, by decreasing aortic diastolic pressure, is also decreased by increased left ventricular end diastolic pressure, also decreased by tachycardia by shortening diastole. What augments coronary blood flow? Increased systemic pressure, decreased left ventricular end diastolic pressure, slowing the heart rate, intra-aortic balloon pumping by increasing the aortic diastolic pressure. What about the coronary flow reserve? Its definition: absolute flow reserve is a measure of ability to augment blood flow with stress. The ratio of maximal coronary blood flow to resting coronary blood flow can be measured easily with intracoronary Doppler techniques. Types of coronary flow reserve: absolute flow reserve, relative flow reserve, fractional flow reserve. Absolute, relative, fractional. What are the differences? Definition: absolute flow reserve, ratio of hyperemic flow to resting flow, and easily applicable in human, applicable to 3 vessel disease. Abnormal value less than 2, it is a ratio. What is the definition of relative flow reserve? Ratio of hyperemic flow in the stenotic region to hyperemic flow in the normal region, independent of driving pressures, easily applicable in humans, and the abnormal value is less than or equal to 0.65. Fractional flow reserve, it is the ratio of hyperemic flow in the stenotic region to hyperemic flow in that same region if no lesion is present. independent of driving pressures, easily applicable in humans, applicable to three vessel disease, and the abnormal value less than or equal to 0.80. Adenosine and papaverine roles in coronary flow research. Adenosine has been the easiest vasodilator to induce maximal vasodilatation because of its short half-life, ability to promote maximal vasodilatation, safety profile. Bradycardia and complete heart block can occur, particularly with injections into the right coronary artery, but they are rare at the recommended doses. Intracoronary bolus of adenosine 24 to 60 microgram for the left coronary arteries and 12 to 36 microgram for the right coronary arteries. Papaverine has a longer half-life, can prolong QT interval, rarely resulting in life-threatening arrhythmias. What about neural factors affecting coronary blood flow? Sympathetic stimulation, coronary vasoconstriction by direct action on alpha receptors in the coronary arteries, the simultaneous activation of the beta receptors in myocardial and also in SE node increases the cardiac metabolic activity. This results in coronary vasodilation, which counteracts the direct vasoconstrictor effect, causing a net increase in coronary blood flow. Parasympathetic stimulation directly dilates coronary vessels, tending to increase the coronary blood flow, but this is followed by vasoconstriction due to heart slowing and inhibition of the cardiac activity, resulting in reduction of coronary blood flow. What about the hormonal factors affecting coronary blood flow? Catecholamine, adrenaline, vasopressin, angiotensin 2. Catecholamine increase the cardiac activity by stimulating myocardial beta receptors, which leads to coronary vasodilation and increases the coronary blood flow. Adrenaline increases this vasodilation by stimulating coronary beta receptors. Vasopressin, antidiuretic hormone, and angiotensin to produce direct coronary vasoconstriction and decrease coronary blood flow. Altered coronary physiology. Obstructive coronary arteries. Clinical manifestations of obstructive coronary artery disease due to coronary atherosclerosis or vasculitis or emboli are caused by altered coronary artery physiology and the resulting myocardial ischemia. Coronary artery stenosis deform the column of blood flow within the coronary artery. Although minor luminal irregularities have little effect on blood flow, more severe stenosis may cause significant transstenotic pressure gradients. The result is a reduction in perfusing pressures distal to the stenosis. Resting blood flow is maintained by what? Vasodilation resistant vessels, which autoregulation. Although this mechanism maintains the resting coronary blood flow, the maximal coronary blood flow will be compromised. Any attempt to increase flow across the stenosis will increase the pressure gradient. Autoregulation fails when the severity of the stenosis severely decreases the distal pressure beyond the lower limits of regulation. At this point, resting coronary blood flow decreases, resulting in resting myocardial ischemia and rest angina. Myocardial viability can be maintained with coronary blood flow as low as 10 to 20 ml per minute per 100 gram if the mechanical activity and the metabolic needs of the heart are reduced, as during hypothermic cardioplegia. Non-obstructive coronary artery disease, endothelial dysfunction, as in cases of diabetes mellitus, hypertension, dyslipidemia, and the lastly overloaded states. Thank you.